working schedule in terms of ORs and outpatient clinics. But now we are almost 95% of our strength. OPDs are full. We are seeing about 180, 200 patients per clinic. So that's fine. And we are back with our full OR strength. So though we do not have the new entrant MCH students yet because the NEET program and everything got delayed, but managing with whatever we have.
Okay, apparently we are live. Okay. So I think welcome everybody. I think to this tonight's or today evening's webinar, which is aimed at again postgraduate students, both for DNB and MS Orth. And today we have the pleasure of having with us Dr. Aashish Gulia from Tata Cancer Hospital, Mumbai. And I think would have a lot to offer for the DNB students and the postgraduate students. So I think we will hand it over to him in a bit. I think we also have the pleasure, hopefully Dr. Ajay Puri will be joining us as soon as he's free from his last webinar. And is Siddharth Laskar joining us or not, Ashish?
Yes, he will join in some time.
And also Dr. Siddharth Laskar, he's an oncologist, isn't he?
Radiation oncologist.
Radiation oncologist. So we're going to have a real sort of panel of experts there today. So, and you can ask them all the questions and try to clear all your doubts along the way. So I think over to you, Ashish, and thank you for being with us today.
Thank you so much, Dr. Mukhopadhaya, for this opportunity to interact with the young budding orthopedic surgeons. And just at the onset, I would like to share a small story about John. I was in my MBBS and my PG in Belgaum, and one of the John's very young admirer, Abhishek Raj, was my roommate, and though I had not met John for decades in the beginning of my career, but I've always heard so much about him, his clinical acumen, and his tennis, that when I met John for the first time, it was not like a new meeting. So thank you so much, and happy to be with you. To start with, greetings from this great institution, Tata Memorial Center, which has been the pioneer of oncology care across the subcontinent. And today, in about next 30 minutes or so, I'm gonna speak to you guys about how do we evaluate a suspected lesion of bone tumor. And Dr. Mukhopadhaya also has asked me to touch upon salient features about the management, though it's not possible to cover everything in one class, but I'll just touch upon a few salient points so that if required, we can have a few more sessions on the same and we can discuss. So bone tumors per se, the exact reason of their having them is not known, but what we definitely know that they arise in the rapidly growing bones. So, and hence these are more common around the knees and away from the elbow. There are some postulations, but nothing have come true, and thus these are considered as to be sporadic. We see lots of benign and malignant lesions in our clinic, and to give you examples, the benign ones are giant cell tumors, fibrous dysplasias, unicameral bone cysts, which are also known as simple bone cysts, eosinophilic granulomas, osteochondromas, osteomas, and non-ossifying fibromas. These are the benign lesions which you see in your clinic. And we also see a lot of malignant lesions like osteosarcoma is the most common malignant bone tumor. We also see Ewing sarcomas and metastatic bone disease as well. So the first question arises that why do we need a proper evaluation strategy for the suspected bone lesions? And the answer is right there in front of you in this slide, where I have broadly categorized these lesions into two main categories. One is the benign and one is the malignant one. So if you go down this ladder, you will clearly see that the kind of treatment which you have to offer for a benign tumor is completely different from the treatment offered to a malignant bone tumor, which is more intense, where you resect more bone, where you involve medical oncologists, radiation oncologists, and hence the treatment is completely different from a benign tumor, where you want to do a function preserving surgery in terms of intralesional curettage and save as much of bone as possible. And hence, it is extremely important to study them, evaluate them in a proper way. So if you get a suspected bone tumor lesion in your clinic, you need to first try to differentiate this, whether it's really a neoplasm or it is something else like infection or a metabolic disorder or a developmental disorder. If you come to a consensus that this looks like a neoplasm or a tumor, then you broadly need to categorize into the malignant one or the benign one. Now, all benigns are not just same. Some benigns are just incidental findings, which are called as latent lesions, which can be like non-fibromas or enchondromas. You can have some slowly growing lesions which are active, like for example, unicameral bone cyst, or you can have very aggressive lesions like giant cell tumor and chondroblastomas. So, and if we look at malignant bone tumors, these are aggressive lesions which destroy the bone more, and we need to categorize them into whether this is a primary bone tumor or these are secondaries from cancers at other sites. So, and hence, as I described earlier, that is extremely important to differentiate them into these broad categories so that the treatment what we offered them is correct and we do not jeopardize with it. So the aim of evaluation is early diagnosis, correct diagnosis, appropriate and optimal staging of the lesion, and then initiate the treatment based upon your diagnosis and staging in a right way. And these are the main aims of your evaluation. We all need to understand that when we want to diagnose a tumor, the diagnosis of a suspected tumor is based upon three very strong pillars. And these pillars are history and clinical findings. Second is, based upon your clinical and history findings, you do appropriate imaging. And these imaging will help you to guide you in a proper direction, whether this is a benign or malignant. But this clinical radiological diagnosis cannot be taken granted, and it must be confirmed by doing a biopsy that is proving it by histopathology. So your diagnosis has to be based upon these three pillars. And if there's any confusion between them, you should be very, very alert. So let's see what salient points we need to look in history and examination. Three important features which we need to look for a swelling or a tumor is patient's age, where exactly it is located in the bone, and obviously what has been the history. And by history here I mean is the history of progression, history of initiation and progression. So if we look at age, I have enumerated few of the lesions which are more common in particular age group. These are available in all textbooks. But what I want you to understand is that most of the primary bone tumors, whether malignant or benign, are more common in younger age group and growing skeleton. First decade has more benign tumors. As we grow older, in second, third decade, we have a lot of malignant tumors coming up. And as we have advanced ages, it is the metastatic bone disease which is more common. Though these are the most common, but obviously there is no exceptions to them. You can have osteosarcoma in a 70 or 80-year-old gentleman as well. So these are the most common lesions according to particular age group, and this classification can help you to zero down to very important differentials. Second thing which I discussed was location. Again, these are the most common sites for these few lesions. But again, as a rule, you can have an osteosarcoma in diaphysis as well, or you can have an Ewing sarcoma in the metaphysis as well. So this picture is also very common in most of the books, but we need to understand that few lesions occur only in epiphysis, few in metaphysis, and few in diaphysis. And based upon that, we have again tried to categorize them, and you can have a look in your textbooks, and it's easily available. Now we look at symptomatology. One of the most common symptomatology with patient which comes to you is the pain. When you are evaluating pain, like any other pain, you need to look at the nature of the pain, its progression and type. And usually is a dull aching pain, which will progress depending upon the growth of the tumor. If the tumor is slow growing, it will progress slowly. You can have different kinds of pain. If the pain is because of destruction of the bone, it will be dull type of pain, which will be boring. But while if you have the compression because of the swelling onto the nerves, you may have radiating or neuropathic type of pain as well. And obviously we are talking about tumor, we need to assess the swelling. I'm not going into details of assessment of swelling, but we need to look at the size, site, how many swellings you are observing, and what is the progression. So I think in this all assessment, progression of symptoms is a very, very important sign, which will help you to differentiate between the benign tumors from malignant bone tumors. Like for example, if a patient says that I have this tumor which has been slowly growing over months to years, that means you are looking at a less aggressive tumor or a benign tumor. On the other side, if you have a swelling which has grown rapidly over a period of time and has not regressed in between without any treatment, looks like that you are dealing with a malignant or an aggressive bone tumor. There can be other symptoms like deformity and inability to walk because of pathological fractures or weakened bone. Very important to understand that in malignant bone tumors, you have distant spread of the disease, and lungs are the most common site for distant spread. Hence, patient who have metastasis to lungs may present to you with respiratory distress, or if they have disseminated disease, then they may have poor general physical health, which we also call as cachexia. Now, after this detailed history, you need to evaluate your patients yourself. And again, I'm not going to discuss each and every part because it will differ from site to site. But the most common things which you need to look at is the size of the swelling, where exactly it is located. How are the margins and the border of the swelling? Is it arising from the bone or the soft tissue? What is its mobility? Is it fixed to the underlying structure or not? How many compartments this swelling is involving, whether it's one compartment or two compartments or it's circumferential swelling. You must also note the previous surgery scars and the drain sites, which are extremely important because we know that the previous scars of the surgery or the drain sites may harbor the tumor cells because of the earlier contamination, and hence these might also have to be excised during the final surgery. Tumors can also spread to lymph nodes, and hence evaluation of lymph nodes in the local examination is very, very important. And last but not the least, to evaluate distal neurovascular function of the limb, again helps you to assess the lesion completely. Now, when we have this all information, we clinically plan to decide whether we can do a limb salvage in this patient or not. And hence, this clinical evaluation will help you to clinch a clinical diagnosis, which will be supported by your detailed history, which you have taken. There are some important hematological investigations which can help you again to clinch diagnosis. We do routine investigations like CBC, LFT, RFT, and coagulation profile because they are also required to look at patient profile and also for doing the biopsy as well. Though the primary bone tumors may not have great tumor markers to diagnose them, but the secondaries in the bone from various other organs or hematolymphoid disorders of the bone like myeloma will have specific tumor markers, and you can diagnose these diseases with the help of these markers as I have enumerated in this slide. So you will look at PSA, CEA, CA125, and you have a complete myeloma profile, which includes urinary Band-Jones proteins and serum electrophoresis, which will help you to clinch the diagnosis even before doing a biopsy, and hence these are important in these situations. So when you have covered history and examination, the next very important step is to do imaging. Now, imaging must be done after history and examination, because what sort of imaging needs to be done, it is guided by your clinical diagnosis. So let's, for example, if you think that on your clinical examination, you find that you are dealing with a very aggressive tumor, then obviously your imaging will be based upon that, and you will also have to do a staging for an aggressive lesion. If you are looking at only a very slow growing benign kind of lesion, then the kind of imaging which you will ask for will be different. So imaging does not only help you to have the correct diagnosis, but they also tell you what is the local extent of the disease, because you need to plan your surgery based upon the local extent. In malignant tumors and aggressive lesions of the bone, imaging also helps you to find the disease distance spread as well. And on the right upper corner, you have a gamut of investigations which are available in today's era to give you all this information. So the pre-treatment evaluation essentially encompasses staging the tumor locally and also look at the distance spread. When we talk about local staging, first and foremost, X-rays are done, and MRI is the best investigation of choice to evaluate any bone tumor locally. As I discussed earlier, that lungs are the most common site for distance spread. Hence, a CT scan, non-contrast enhanced, will be the investigation of choice. And we also know that malignant bone tumors can also spread to other bones, and hence a bone scan will also be required. I'm just I'm just mentioning a few important points about imaging here as well, so that we learn how to prescribe the right imaging and how to read it as well. So whenever you are prescribing X-ray for a bone tumor, you need to ask the imaging in two perpendicular planes, that is AP and lateral, and you must scan the entire bone, including a joint above and below. Because malignant bone tumors can have skip lesions in the bone, and if you do not scan the bone completely, you might miss these lesions and you may treat them inadequately. Similarly, when we are doing three-dimensional investigations like MRI, this should include all sequences. And we should have a dynamic contrast enhanced MRI to give us more information. And again, the entire bone, including a joint above and below, should be scanned. For distance spread, as I mentioned earlier, we have CT scan of the chest. It can be a non-contrast CT scan of the chest with thin slices. To look at the bony metastasis, we have bone scan. And now we have a new investigation called as PET scan, which can help us to evaluate the entire body, and it is useful in many of the diagnoses. Now let's spend 2 to 3 minutes on looking at the plain radiograph. And let me open the slide completely so that you can read it while I'm talking. Whenever you get a suspected lesion, a bony tumor lesion in a radiograph, you need to look at these 4 parameters in detail. First, the type of the lesion you are seeing. Lesions can be completely lytic. Lesion can be completely sclerotic. That means they have ossification, or there can be a mixed picture of these. So you need to categorize the type of lesion seen into these 3 categories. Then we move on and we talk about something called a zone of transition. Now, zone of transition is defined as an area where normal bone meets abnormal bone. So like, for example, here this area looks like that this is the place where normal bone is meeting abnormal bone. Now, this can be very well defined and it may not be very well defined. Now, how to differentiate? If you can take a pencil and actually you can draw this zone of transition where abnormal bone is meeting the normal bone, it is called as a well-defined zone of transition. Now, how it helps us to clinch diagnosis or to differentiate malignant tumors from benign tumors. Analogy here is, like, for example, you have any sort of flu-like symptom, not COVID, but any usual flu-like symptom. Your immunity takes over, and over a period of time, it heals. So body's immunity actually tries to heal the disease and you get well. Same sort of immunity is acting into a bone if you have a lesion or a pathology in the bone as well. The rate limiting factor is the rate at which the bone can stop it. So if you have a pathology which is slow growing, where the tumor cells are not replicating very fast, this slow growing pathology, the normal bone tries to throw a lot of bone around the periphery of this lesion, and you get a very well defined thick sclerotic margin that is called as a very well defined zone. On the other hand, if you have a lesion which is growing very fast, the biology is worse and the tumors are growing very fast, the bone rate is not good enough to stop it, and it goes all around the marrow, and you see the infiltration into the marrow, which can be termed as, like we have geography pattern in benign tumors, then we have permeative destruction in these malignant bone tumors. Hence, this zone of transition tells us about the biology of the disease or the growth of the disease or the progression of the disease, and hence it is very, very important. Third thing which you need to assess is periosteal reaction. Having a periosteal reaction doesn't always mean that it's a malignant bone tumor. Periosteal reactions can be benign and they can be malignant as well. Like, for example, in this X-ray, you are seeing that there is some periosteal reaction happening on this side, and you have some periosteal reaction happening here as well. So this periosteal reaction is interrupted. This is hair on end, and if we leave for some time, it might form a Codman triangle as well. So that means this is an aggressive periosteal reaction. But if you have a periosteal reaction where in a slow growing tumor where bone is capable enough to throw a lot of bone in that area, it becomes a buttress type of periosteal reaction, and that is typically seen in benign bone tumors. Okay, so you need to differentiate between malignant periosteal reactions and benign periosteal reactions. And the last point is about the matrix. Matrix is the substance which is produced by neoplastic cells. Now, how we define matrix? We say some tumors have osteoid matrix. That means, like, for example, osteosarcoma will throw an osteoid matrix. Chondroid lesions will throw a chondroid matrix, which will appear like walls and arcs in the X-rays. Some lesions may not have any matrix on X-ray. That doesn't mean that they do not have matrix. They have matrix, but that matrix is not visible on the X-rays, or it is transparent sort of matrix. So it is not visible on the X-rays, and such lesions are type of lesions categorized separately. Now, based upon the kind of matrix you see, again, you can categorize these lesions into whether this is an osteoid producing matrix or a chondroid producing matrix. So you know the origin of the tumor cells. Now, I can assure you, if you pick up any X-ray in your clinic and you try to categorize the lesion based upon these findings, 80 to 85% of the times you will be able to get a correct diagnosis. So let's do one example. For example, if you have a lesion in an 18-year-old boy, which is located in the metaphysis, the lesion is sclerotic type, it has osteoid matrix, it has a not well-defined or a wide zone of transition, and it has aggressive periosteal reaction. All put together, we definitely know that we are dealing with a malignant tumor of the bone, which is osteoid producing, and that is osteosarcoma. On the other hand, if we look at a lesion in an adult skeleton, which doesn't have much matrix, it has expansion of the bone, no periosteal reaction, ballooning of the bone, and some cystic changes, if you can see, then we know that we are dealing, and this lesion is reaching up to the subchondral bone, we know that we are dealing with a giant cell tumor of the bone. So hence, if you take all these parameters and try to categorize each and every X-ray, then we can reach a good clinico-radiological diagnosis in more than 80% of the cases. As I discussed earlier, MRI is the best investigation for local assessment of the disease, because it not only tells you the right extent in the bone and in the soft tissue, but it also helps you to delineate the relationship of disease with the important vital structures like nerves and the vessels. It tells you about skip lesions in the bone and also involvement of the adjacent joint as well, and hence very important for planning your surgery. As discussed earlier, CT scan is the investigation of choice for staging and looking at the lung disease, and bone scan for the distance spread in the bones. I was mentioning about PET scan. This is a new modality which is coming up. It is helping us to diagnose distance spread of the disease pretty early in various disorders, but obviously it is an expensive technique. And at present, it is pretty helpful in Ewing sarcoma staging and in few chondroid lesion staging, because it helps you to stage Ewing sarcoma without doing invasive biopsies, and can help you to differentiate between low grade and high grade chondrosarcomas as well. So the role of PET scan is still evolving, and I'm sure we'll have more studies and data to define its role clearly. Now, when we have information from detailed history and examination, we have done appropriate imaging. Now we have a clinico-radiological diagnosis. Now, at this stage, you cannot start any treatment, because this clinico-radiological diagnosis must be confirmed by doing a biopsy and prove histopathologically what we are dealing with. Just to show you the importance of doing biopsy, this case was actually referred to by one of my colleagues way back in 2011. You can see a lesion which is located in the distal end of the femur in a mature skeleton. There's no periosteal reaction, lesion reaching right up to the subchondral bone. There is no matrix as such. So it looked like giant cell tumor of the bone. The guy did not do the biopsy, and presuming it to be the giant cell tumor of the bone, he did the curettage, took bone graft from iliac crest and did bone grafting. And eventually, when he referred patient to Tata Memorial Hospital for further evaluation, we found that it was a high-grade spindle cell sarcoma. So what we need to understand and learn from today's lecture is that irrespective of how typical the imaging appears on X-rays or on MRI, if you want to initiate any kind of treatment, whether it's radiotherapy, chemotherapy, or surgery, you must have a histopathological diagnosis, and only then you can go ahead. I was also supposed to touch upon biopsy, but biopsy itself is a big topic, but I've added a few slides here. And these slides are from an article from Professor Mencken, which actually talks about hazards of doing a wrong biopsy. And that's why I want to highlight that biopsy is not a simple procedure that we ask one of the juniors to do it. It is extremely important procedure to get the correct diagnosis, and wrongly done biopsies can cause a lot of harm. As you can see the jigs from this paper, the diagnostic error even in the United States happened about 18% of patients. About 17% of patients had wound problems. Treatment plan changed in about 18% of patients. About 4.5% of the patients underwent unnecessary amputations because of doing wrong biopsies, and all these complications were much higher if these were done in non-sarcoma treatment centers. And they clearly mentioned that patient who require biopsy, his biopsy should be done by people who treat these tumors day in, day out. And if you do not have adequate experience, they should be referred. When we talk about biopsy, there are a lot of questions, and I said that today maybe the time is not adequate to address all of them, but few salient points which you need to understand is that needle biopsy is the investigation of choice or the method of choice for doing histopathological evaluation for malignant bone as well as soft tissue tumors. And there are very specific advantage of it. It's a very simple procedure which can be done in the outpatient clinic under local anesthesia. Practically no infections. We do not give any antibiotics. Very little tissue contamination happens. If required, you can use various image guidance like ultrasound and CT guidance for doing this biopsy from difficult locations like spine and sacrum. And you can actually approach different areas of the lesion from the same track, and accuracy is also pretty high. So in a nutshell, needle biopsies are minimally invasive, they are cost effective, They are less traumatic and have much less complications as compared to open biopsy. And this is all what you need to do a needle biopsy. Simple Jamshidi needle, local anesthesia, and one stitch. And this is how we do it. We clean and drape, we give local anesthesia, and then you have the exact site mark. After that, you give local anesthesia, a small stab incision on the line of the incision which you are planning for the final surgery. And then you use Jamshidi needle, and with the rotatory movements, you put the needle in, pull it out, and then you just close with a simple stitch. And this is how it looks, such a small lesion, and then you can do dressing. Another very important point we need to understand is that you cannot right away jump to the biopsy in the first go. The evaluation has to be done in a proper sequence, and there are specific reasons for it. Unless and until you have clinical suspicion, you will not ask for detailed history about it. Unless and until you have taken a good history, you will not perform the right clinical examination. Unless and until you have the right history and clinical examination, you cannot ask for appropriate imaging. And unless and until you have appropriate imaging, you will not be able to plan your biopsies, because these tumors are heterogeneous. They may have necrotic areas, and if you do not do imaging properly, you may end up hitting those necrotic areas. You may not get your correct diagnosis, and hence this sequence is very, very important. So once we have these all three things with us, then we have the correct diagnosis, and then we need to evaluate our patients further. Now let's spend a few minutes on staging. Now staging differs for various tumors in different way. For locally aggressive benign tumors, where the chances of distance spread is very less, the imaging done to look at the distance spreads are also very minimal. So like for example, in giant cell tumor, we just do an X-ray of the chest, unless and until patient is having symptom in the other bones, where we need to look at the scanning of entire skeleton. For Ewing sarcoma, we need to do local staging as well as distance staging. In distance staging, either we can use a PET scan, which can obviate the need of invasive bone marrow biopsy from two sides, in addition to a CT scan of the chest and a bone scan. If we are talking about osteosarcoma, the gold standard till date is still the CT scan of the chest and the bone scan, but role of PET scan is also evolving in major way. When we have this investigation, then we categorize or summarize these lesions into various stages. And there are two systems which we can use to stage these tumors. A simpler one is Anneking or MSTS staging system, and a bit of complicated elaborate is AJ system of classification. Anneking, considered as the godfather of musculoskeletal oncology, he gave staging for benign tumors, as I discussed earlier, latent, active, and aggressive, and also gave for the malignant bone tumor, where he categorized these lesions into three simple stages. Any low-grade tumor is stage 1, any high-grade tumor is stage 2, and any metastasis is stage 3. If you have smaller lesions within the compartment that is within the bone, it becomes A of that stage, and if it is outside, it becomes B. So hence you have 1A, 1B, 2A, 2B, and stage 3. Simple to remember, many people follow this. AJ system is more specific, but it's more complex as well. It's based upon various parameters like primary site, lymph node involvement, and metastasis. Here, the lesions are categorized depending upon the size. Less than 8 centimeter is T1 lesions. If you have a lesion which is more than 8 centimeters, it is T2. And if you have a skip lesion in the same bone, it becomes T3. Nodal involvement becomes N1. And if you have metastasis in the lungs, it is M1A. And in other than lungs, it is M1B. And that's how you get this grouping. And this grouping actually tells you about the kind of treatment and the prognosis of the patient. And this is what is highlighted here. That when we do all these investigations, we answer two important questions which every patient asks us. What sort of treatment, doctor, you going to offer me? Whether it is just surgery or surgery and chemotherapy, or it's a curative intent treatment or a palliative intent treatment, and what is my prognosis, whether I'm going to live or not. This is what staging will tell you. A few very important points before we take our first break is the concept of multidisciplinary approach. We need to learn that we cannot treat malignant or benign bone tumors alone. You need a team effort to diagnose them correctly. So you require a very good radiology support. You require a very good pathology support to come to a correct diagnosis. And when you start treatment, obviously you require help of various colleagues from medical oncology and radiation oncology, and obviously other supportive treatments like occupation therapy, physiotherapy, rehabilitation therapies, psychological support team, so that you form a team and then treat these patients. And there have been a lot of literature which talks about that when these patients are treated by multidisciplinary team, the outcomes of these patients are better than when these are treated in isolated centers. So I think we'll just take a break here, John, and if we have a few questions related to the evaluation and staging, I think we can take these questions here, and then
sure.
I'll touch
Thank
upon.
you, Ashish. That was great. I think welcome to Ajay and Dr. Siddharth Laskar from Tata Cancer Hospital, and it would be great to have you in the discussion. So I think we should go on to questions from the DNB students. Hi, Ajay. Hi, Siddharth.
Hi. Good evening, sir. So Avinash and Gautam, we have. So if you have question, please ask.
Yeah, you won't get an opportunity like this where you'll have all these great people there to give you answers for your difficult questions.
Yes, sir. So one thing I want to ask you: how aggressive lesion is different from malignant lesion?
So aggressiveness, you can have some benign lesions which are aggressive. Aggressiveness is only in terms of the growth of the lesion. So like, for example, giant cell tumor are very aggressive lesions which grow very fast, but they're essentially not malignant tumors. Malignancy means that they spread to the different parts of the body and the spread is pretty rapid. So infections can also show us very aggressive lesions as well. So aggressive lesion essentially means the rapidly growing lesions, which can be infections as well as, and you can have some benign aggressive lesions also, like giant cell tumors, chondroblastomas, aneurysmal bone cysts.
Ashish referred to the word aggressive. I think he was talking in a radiological context. It's not actually characterizing whether you're calling them benign or malignant, but he was trying to define the radiological aspects. When you look at an X-ray, based on the zone of transition, based on the periosteal reaction, whether that would be a sort of slow growing lesion or a more actively growing lesion. And that was the context in which the term was used.
And what additional information we can get from PET scan?
Ashish, you want to take that?
Sorry, I was just reading the question.
Okay. So a PET scan is only an indicator of biologic activity. PET scan is not going to tell you whether the lesion is benign or malignant, whether it is infection or because of trauma or not. What it gives you is a measure of the biologic activity of the disease, both locally and whether there is a presence of a biologically active lesion elsewhere in the body. So there is a distinct sort of way that you use PET scan. It is not a magic answer to everything. You have to use it in conjunction with the other investigations that are available to you to reach an overall picture about your diagnosis.
So as Dr. Puri told that, PET scan is an investigation which actually looks at the glucose metabolism. So wherever you have higher glucose metabolism, PET scan will show uptake. So it is very evident in infections as well. It may be evident in rapidly growing benign tumors also. So it will just tell you the lesion and the sites of the lesion in the body. It is up to you to differentiate whether that is actually a malignant pathology or it's an infection or it's something else.
Maybe it would be better to look at what PET scans tell you that the bone scan can't, standard bone scans can't. Ajay?
Yes.
John, actually, it's more or less the same thing. A PET scan would be a little more quantitative because a bone scan gives you an indication of biological activity. Yes, there are ways that you could, rate the quality or the quantity of the activity compared to when you're comparing to uptake in the iliac crest. But the PET scan gives you a more quantitative aspect. And realistically, the only place where we use PET scan to help us make decisions about treatment is in chondroid tumors, because chondroid tumors are challenging both for the radiologist and the pathologist. Whether it's an enchondroma, a low-grade chondroid lesion, or an aggressive chondrosarcoma, in a few cases, radiology and histopathology can both be challenging. And there is where we use the quantitative value, or what is known as a standard uptake value, as a guide. That is still not an absolute, has to be taken in conjunction with the other features. And that's the one area where a PET scan may help you. Also, a PET CT, a bone scan gives you only the sort of osseous uptake. A PET scan will also enable you to see if there is uptake in soft tissue components. So it is more sort of comprehensive if you're comparing it vis-a-vis just a bone scan.
So just to add to what has been told, so in my opinion, what as a student we should know is, for any radiological investigation, we should look at what are the utilities in terms of diagnosis, staging, prognostication, and follow-up. So when you're looking at a PET scan or a CT scan for a particular disease, I think you should look at all factors. In terms of diagnosis, how does PET scan help you? In terms of staging, does it help you? In terms of response assessment, does it help you? And in terms of follow-up, does it help you? So if you classify things that way, you would be better able to understand the utility of each modality better. So that applies to PET scan, MRI, CT scan, everything.
Okay, so there are a couple of questions from the DNB students on the chat. One is asking how to differentiate clinically between spinal tumors and spinal infection. And the second one is follow-up protocols in terms of radiology after malignant tumor surgery, such as a megaprosthesis.
I think we need to classify that question. It's too broad.
Yeah, I know, it's really very broad. The
spinal clinically, you can't differentiate between spinal tumor and spinal malignancy. They are both going to present with backache and or not a neurological deficit. So Ashish, I think, repeatedly stressed in his talk that it is a combination of clinical picture, X-ray, and histology. All three have to be matching with each other for you to reach an accurate diagnosis. I mean, clinically, if it's a rapid onset disease, radiology looks quite aggressive, and the histopathology calls it a benign, slow-growing tumor. There is a mismatch somewhere, or vice versa. So you're not going to look at, you have to remember that you don't look at anything in isolation. It's all a combination of all three. And maybe I missed it because I joined late, but infection is a differential diagnosis for everything, especially
and very often
in our country with tuberculosis. So we at Tata Memorial Hospital generally see tumors and they are referred to us. We also have more experience with tumors. But for a general orthopedic surgeon, it would be a good rule that you culture whatever you biopsy and you biopsy whatever you culture. Because infection can look like anything. Even a Ewing sarcoma, necrotic, if you incise, comes out looking like pus. So that doesn't mean that it is pus. So if you have a doubt, send it for culture, even though you suspect a tumor. Vice versa, if it is infection, you don't lose anything by sending it for histopathology. 9 times out of 10, your clinical diagnosis will be correct. But in that 1 out of 10 cases in which you have possibly made an error, it will help the patient greatly.
Yeah.
In addition to what Dr. Puri said, infections are always the first differential, especially in spine, actually. And if you look at the metastatic spine disease, and spine is the most common site for metastasis from other organs, it is very, very difficult to differentiate between them. A primary tumor of the spine may be a bit easier to differentiate, but clinically they are going to present with the same sort of symptomatology. A primary tumor may have a bit of bone growth or some sort of radiological picture different, but it is extremely difficult to differentiate between a metastatic bone disease and infection, and we should be very careful about it. Second question, which was asked about how do we do the surveillance and follow-up. I have a few slides in the end, and I think we'll answer that question.
Sure.
Sir, I have one question.
Yes.
Sir, while examining the patient of a suspected bone tumor, is it necessary to examine a spine also in every patient?
Not really, not really. But obviously, I mean, the tumor examination essentially involves the local site. But yes, you also take a detailed history whether patient has similar symptoms or swelling anywhere else in the body. Now, as we know that the disease can spread to the other parts of the body, so hence you need to be very, very careful in evaluating the entire skeleton. And you should not miss asking, if you are suspecting a malignant bone tumor, you should not miss asking about the respiratory distress, because lungs are the most common sites. Now, if you're asking me a question about the secondaries of the bone, and like, for example, if you get a case with a known case of CA breast, then obviously we know that the spine is the most common site, and hence examination becomes extremely essential. So it depends upon what sort of case you get and what is your history guiding it to, whether it's a primary tumor or it's a secondaries.
Thank you, sir.
Listen to the patient.
So are there, so when you're looking at, sorry.
Very unlikely that you will generate something on examination that a patient is not complaining about. So if you listen to the patient and a patient complains of backache or issues with the back, I'm not saying it's a tumor, it could be some other pathology, but you will get that information. So if a patient was absolutely symptom-free, never referred a word to the back, I sincerely doubt that just examining the back in a tumor elsewhere, you'll get something.
So what are the benign tumors that you would go ahead and treat without a biopsy? Say like an enchondroma, would you be happy treating that without doing a biopsy, or would you in the finger?
For the students, no tumor is treated without a biopsy.
Okay, so is that now, so even a simple bone cyst?
Yes, John.
Simple bones don't require treatment, John.
No, they do need treatment.
No. So what I'm saying is, see, this is an undergraduate lecture. So what I would say is, unless there is really something, you're damn sure your clinical examination, your MRI and your experience suggests nothing, a good rule to follow would be that do not definitively treat anything without a biopsy.
So something like an enchondroma in a finger, I just want to, this is enchondroma in a finger without any signs of malignancy. Would you,
so in a
biopsy, or would you curate it and biopsy it at the same time?
So in a finger, one, you specified, fortunately for you, that it's an enchondroma. Or an enchondroma elsewhere doesn't require treatment unless it is symptomatic. If it is symptomatic, that is the first sign that something is wrong and you need to biopsy. Yes, in the finger and the foot, you can have these small bone lesions look a lot more aggressive, both on radiology and pathology, yet behave in a benign manner. But I would still say, and we do that even at TMH, in spite of, if I say so myself, our vast experience, we will not do a definitive treatment unless we have biopsied the tumor.
Okay.
We always teach that you need to have a histopathological diagnosis if you want to start any kind of treatment, whether it is surgery or chemotherapy or radiotherapy. Very limited indication, very limited indication, that too in a very sort of secure, reserved environment where you have a lot of experience, that you will do a definitive treatment without it. Like, for example, just in addition to what you said and Dr. Puri said, osteoid osteoma,
Osteoid osteoma.
Yeah. So, but even in those cases, we would have evaluated patient's history and appropriate imaging a couple of times, and we would have really made sure that it really looks like osteoid. In addition to that,
Osteosis for that matter.
Yeah. In addition to that, we always make sure that the kind of we are doing will not, in case by chance, if it turns out to be, malignant, it should not hamper the what kind of medicine. Like, for example, osteoid osteomas, we always treat them with radiofrequency ablation. So it has not happened that if we evaluate all this patient very carefully, it has not happened yet, at least I'm not aware. But if in case it is something else, then we know that we only have treated the patient with a small needle track, and it won't cause any further issues with the treatment. But for teaching undergrad students, we must remember that we need a histopathological diagnosis before embarking on to kind of treatment.
Example,
So-
that X-ray of what looked like a giant cell tumor that turned out to be an osteosarcoma. That X-ray is shown to 10 orthopedic oncologists. 10 out of 10 times you would have called it a giant cell tumor. I mean, that would have been our first diagnosis. And yet, unfortunately for the patient, when it was treated without a biopsy, it turned out to be an osteosarcoma. So yes, that is the rare case, but that is the one rare case that you want to avoid, and that's why you follow all these standard protocols.
And we see that quite often happening. I mean, it's not that it's not being done. We see a lot of situations where, you know, it's very benign looking lesion, especially ABCs can get different, mixed up with telangiectatic osteosarcomas and osteosarcomas with giant cell tumors. It happens quite often, and hence we need to be very careful.
Those are the two lesions, John, you mentioned a UBC. So UBC unlikely to muck up. But once an orthopedic oncologist sees fluid levels on an MRI and the radiologist calls it an ABC, you just rush in. And you have to be worried that a telangiectatic osteosarcoma can look like that. And then once you sort of do an aggressive curettage with spillage, both of them bleed like hell, contaminate locally hell, you've actually just lost the battle. You need to be wary of these lesions.
Let me generate some questions for the students. Dr. Puri, a lot of people ask that,
Before you,
Sorry, Dr. Lakar wanted to say.
Yes, Dr. Laskar.
No, I just had a suggestion. I don't know if we missed out the beginning of your talk. I think it is very important for the students to understand the basics of differentiating between a benign and malignant on a plain radiograph versus those things are extremely important because that is really basic. And when you investigate, what are the things that you look at? So it's benign, malignant infections. So that is important. I hope you've covered that in your talk.
Yeah, that was covered.
Okay.
I spent about
sort of stressing what Laskar says. In this era of technology, we see so many patients come to us with an MRI and no plain X-ray.
Yes.
You have to remember that for orthopedic oncology, your plain X-ray is still the gold standard for diagnosis. 9 out of 10 cases, as Ashish told you, if you follow the SOP that he listed out, you will get a diagnosis. So it's absolutely unpardonable to have an MRI without having an X-ray done.
And John, what is your view on students taking detailed history nowadays? Because, you know, we have always been trained to, you know, diagnose the patient with detailed history. And that's why I was stressing on my first few slides that history can actually clinch the diagnosis or at least differentiate between a malignant and a benign tumor, and hence can guide you what sort of way we need to walk on. So what you have seen, because you see a lot more younger colleagues.
Yeah, so it's gradually becoming a forgotten art, but I think you can't emphasize more than enough that what you pick up on history is often more important than anything else that you do. It also guides you in which direction to investigate the patient. So until you have a good history and a good clinical exam, you are likely to head in the wrong direction. I mean, and we have innumerable examples of patients with that kind of issue.
Sir, we have one question in the chat box, sir.
Yeah.
That Kautam want to know, can you give a stepwise guideline for investigation in spine mets? I mean, how to proceed stepwise.
Metastasis.
Metastasis of spine.
I think that itself will be a full lecture on.
Yeah.
And I think
maybe we cover it some other time.
Yeah, so we can cover some other time. But yeah, there are guidelines available, and we can cover it some other time. So Dr. Puri, let me ask some questions.
Sir, but I also think that the residents and the students need to put in a little effort and do reading. All this is available, very well elucidated in multiple articles. Yeah, I mean, the desire that Dr. Gulia has to sort of stepwise list, yes, if it was a special lecture on spinal meds, fair and justified. But all this is actually available, and it's not just any residents. Even my own residents, I keep saying that a little bit of effort on your part is desirable to do a little. Ashish is smiling there, and do all this. All this is, no matter how brilliant, has still not discovered everything in the world. It exists before he speaks. It's all documented before.
Okay, so Ashish, you have some more slides to show?
Yeah, so I think we will cover those slides because I will just touch upon few important points in the management part quickly in about 10 minutes or so.
Sure.
So again, the repeat of the slide which I had put in the beginning, that we essentially need to categorize these lesions broadly into two main categories, that is benign and malignant, because we know that from there on the path we walk on is completely different. The kind of surgeries we do is different. The kind of multidisciplinary management required is different, and the outcomes are also different. And if we try to treat one with the other, we're going to end up in disaster. Very important to understand that if you are looking at benign bone tumors, you are doing function preserving surgeries, which are essentially intralesional curettage, and then reconstruction of the cavity with either cement or bone grafts, and resections are required in quite less number of patients. And here we do something called as intralesional margin of resection. While malignant bone tumors, we need to understand that these tumors require inputs from various other modalities like medical oncology and radiation oncology. The kind of surgeries here do are much bigger and wider, and we excise the tumor completely. We actually never see the malignant tumors operatively, and requires much more efforts for reconstruction as well. So I'll just highlight this slide, and again trying to tell the students that, you know, based upon various kind of diagnoses you get, you can actually see that apart from your effort as a surgeon, you require help from medical oncology and radiation oncology in almost all type of tumors here. So surgery becomes very essential in osteosarcomas because we need to excise the tumor completely. Chemotherapy again is must to improve the outcomes and to prevent metastasis, and radiotherapy has role for pain control and palliation, but now the role is increasing in unresectable osteosarcoma, and I will show you a couple of slides on that. Ewing sarcomas it's a bit complex. Chemotherapy again is must. We as far as possible, and wherever we can take the tumor out completely without much morbidity, we tend to operate these patients. But if we cannot, like for unresectable tumors of the spine or sacrum where morbidity is very high, we can treat this patient with definitive radiotherapy as well. Adjuvant radiotherapy also has very specific role in Ewing sarcoma also, and I think today's time is not adequate to discuss that in detail. Chondrosarcoma, the conventional chondrosarcoma essentially are surgeon's disease, and if you take them out completely, you can cure this disease very well. Soft tissue sarcoma again require multidisciplinary management. Surgical resection is essential for cure. Radiotherapy has been the integral part of to have a better local control, and we have some advantage in some specific histopathologies by giving adjuvant chemotherapy as well. So this slide summarizes in a nutshell that in various pathologies, what kind of treatment you need to offer. When we talk only about surgery per se, as orthopedic surgeon, and I'm highlighting that, you can do two kind of surgeries to remove the tumor completely out of the body. One is limb salvage, where you remove a part of the bone and then do adequate reconstruction to provide good function. And if you cannot do that, you perform amputation and remove the disease out. But while doing limb salvage, we need to understand very well that first we have to be, you always keep the oncological aspect higher. That means remove the tumor first and not think about reconstruction more than oncological aspect. Functional part comes secondarily, because whatever nice functional reconstruction you do, if your disease removal is not adequate, the patient will get local recurrence and all that going to be in vain. When we are doing limb salvage, again, you can divide into two simple steps. First is the resection of the disease, like you can see here, where osteosarcoma of the proximal tibia has been resected, and you have the tumor specimen along with the biopsy scar, and you have the big gap. And in the second part of the surgery, you reconstruct with various modalities available, and here in this case is a megaprosthetic reconstruction. We also need to understand the concept of margins. And King gave this concept of margins, which are MSTS surgical margins. Intralesional, as I discussed with you, where we go inside the tumor and remove the tumor out. That we typically practice in various benign tumors like giant cell tumors of the bone. When we remove the tumor along with the reactive zone along the capsule, it's called as marginal resection. When we take out the tumor along with a good normal bone cover around it, it is called as wide margin of resection. And you saw the example, a slide before, where we have excised the osteosarcoma of the proximal tibia with good margin, that is wide margin of resection. And if you remove the complete compartment where disease is there, it's called as radical resection. So adequacy of margin is defined as 2 to 3 centimeters of normal bone from the disease and a coat of healthy muscle around the tumor. You may be focally close around important structures like nerves and vessels. Now, when you get this defect, you can reconstruct it with various modalities. You have various non-biological modalities like endoprosthesis or megaprosthesis and temporary spacers. And this is one example here where osteosarcoma of the distal femur, as you can see in the X-rays and the MRI, has been reconstructed with a megaprosthesis. And this is the function at 4 years after reconstruction with the megaprosthesis. These patients do pretty well, walk without support, and good imported prosthesis can survive for decades as well. We have biological options as well, where you can use various bone grafts, which can be patients' own autografts, or you can have allografts, which are available from the bone banks as well. And we have various procedures which we can do with the help of these bone grafts, and I'm not going into detail of that. Another very important is that we can use the patient's tumor-bearing bone. We can sterilize it. And Dr. Laskar is with us today, who has really helped us to do this procedure called as extracorporeal radiotherapy, where we resect the bone, send it for radiation, get it back, and put it back in the body at the same time. And these kind of procedures really help us to do a lot of cost-effective reconstruction in our patients. And we can also do something called as rotation plasty. This is an 8-year follow-up of a patient who had osteosarcoma of the diaphysis of the femur. We did a resection, extracorporeal radiotherapy, and then replanted the bone back, and this fantastic union and good function at the end of 8 years. And this patient is doing pretty good. So this is one of the example of biological reconstruction. Pelvis is a very difficult area to resect and reconstruct. What we believe is in using simple mode of reconstruction, like doing pseudoarthrosis with the help of mesh. And we have very good outcomes with this modality, especially in pediatric age group, and we published the same. Nowadays, we have also started using computer-assisted navigation for better resection and reconstruction of these lesions, specifically in different areas like sacrum and pelvis, or areas where we want to go very close to the physis and save the joints. And this is also helping us to have better resection and reconstructions. So ultimately, you have a lot of options available, but there are various factors which helps us to decide what is the best option for one particular patient. And this includes what kind of tumor you are dealing with, whether it's benign or malignant, whether this tumor require any adjuvant therapy or not, what exactly the site of the tumor and the size of the tumor, what is the age of the patient, patient's functional demands and lifestyle expectations, and obviously what kind of experience we have with us and the infrastructure available. That also governs what sort of reconstructions we can do. Few slides on chemotherapy, which is extremely essential. And this slide actually shows the difference in the outcomes of osteosarcomas treated after and before invent of chemotherapy. And you can actually see that without chemotherapy, almost everybody was dying in long term. And with giving chemotherapy, the survival has gone as high as 70 to 75%. Hence, chemotherapy is essential for Ewing sarcoma and osteosarcomas. And a lot of students must have heard about neoadjuvant and adjuvant chemotherapy. The chemotherapy which is given before the local therapy is neoadjuvant, and which is given after completion of local therapy is called as adjuvant therapy. I'm not going into detail of it, but just mentioning that for osteosarcoma, we use these 3-drug regime, that is adriamycin, ifosfamide, and cisplatin, to treat these patients in 8 cycles, 4 before and 4 after surgery. You can also have methotrexate-based regime as well, but we do not practice that in TMH. For Ewing sarcoma, again, you have neoadjuvant or induction therapy before the local therapy. As I mentioned earlier, it can be surgery or a definitive radiotherapy in areas where we cannot resect or have morbid resections, and then followed by maintenance or adjuvant chemotherapy, which is a complex chemotherapy protocol given over a period of 9 months. Once you have excised this specimen, you need to evaluate this specimen for the complete resection, which we mark by looking at the margins of resection, and also we look at the response to the chemotherapy given, which is looked by looking at the percentage of necrosis which a tumor has undergone after giving chemotherapy. By this, you can categorize these tumors and prognosticate your patient in a good responder group and a poor responder group, which have different outcomes. So when we talk about prognostic factors, metastasis is the single most prognostic factor at presentation. Single or isolated pulmonary metastasis, these patients do better than the patients who have multiple metastasis. Obviously, non-metastatic patients always do best. Larger tumors and the tumors located in the areas where they are difficult to resect completely have poor survival as compared to the patients who are not. A good response to induction chemotherapy, as I discussed earlier, will have better outcomes. And if we have resected the tumors completely, then these patients will have better outcomes. Role of radiotherapy is limited in osteosarcoma and chondrosarcomas. It has a very important role in Ewing sarcomas and soft tissue sarcomas. Now, the role of radiotherapy in unresectable osteosarcoma and chondrosarcoma is increasing a lot. And we have a lot of papers coming up in last decade or so, where heavy ion therapy in terms of carbon ion therapy and proton beam therapy has been used at unresectable sites, and local disease control are quite promising. And proud to say that Tata Memorial Hospital will also have such a facility in a few months from now. And hopefully these patients with unresectable lesions will have better outcomes. As I discussed earlier, that the role of postoperative radiotherapy in Ewing sarcoma is much more important, and it is given in patients where either we had close or positive margins, where we had planned positive margins or marginal resections, in patient who had pathological fractures at presentation or during the treatment, or the patient who presented with very large volume disease. Here we give post-operative radiotherapy to have better outcomes, which has led to better survivals as well. So I'm ending with few slides, and actually these are snapshot of the guidelines which Tata Memorial Hospital has formed. These are actually freely available at Tata Memorial website. As Dr. Puri also told you, that you just need to make a bit of effort, and a lot of simplified version of treatment guidelines are available. You can visit Tata Memorial Hospital and you can have access to these guidelines completely free. This is for high-grade osteosarcoma. Similarly, we have for Ewing sarcoma and chondrosarcoma as well. So I think I'll end with last slide, where somebody spoke to me about how to evaluate these patients over a period of time after doing the surgery and completion of the treatment. So surveillance is a very, very important part, because by treating the tumor per se initially, it doesn't cure the patient. These disease can relapse either locally at the site of the disease or distance elsewhere. We need to plan a particular program for these patients, which will be at specific intervals. And at every visit, they will have specific investigations based upon the diagnosis and the biology of the disease. Usually, we follow our patients anywhere between 3 to 6 months for first 2 years, and then every 6 months later on. If you are looking at in TMH, looking at the TOS study, which is the first and actually the only randomized control study, we found that if you follow our patient every 6 months, the outcome of these patients is equivalent to the patients who have been followed at a shorter interval with intense investigation as well. But sometimes we call our patients early for looking at reconstruction and other parameters also. So extended surveillance is also required for some disease where which relapse late, like chondrosarcomas. And obviously you also want to look at long-term side effect of the treatment, like chemotherapy or radiotherapy. And obviously the kind of reconstruction you have done, their failures, you need to evaluate them over a longer period of time. So these patients are usually followed for decades as well. So this is in short about evaluation, and I've touched upon the points about management of malignant bone tumors. And I think if there is some time, we'll be happy to take a few questions as well.
Yeah, okay, thanks a lot, Ashish. Can we have the questions now?
Yes, sir. Sir, I have one doubt about the biopsy, sir. When we are doing frozen section,
Janki, you are mute, I think.
Now you are able to hear me, sir?
Yeah, we are able to hear. I don't know about Ashish.
No worries. I'll take the question.
Okay, sir. Sir, when we are doing the frozen section, it takes about 20 or 30 minutes. But when we are doing biopsy, yeah, when we are doing biopsy, it takes about 8 to 10 days. Why it is so, sir? What is the difference?
Frozen section, there is a difference in the techniques of frozen section and in definitive biopsy. You cannot do a frozen section on bone. Bone requires decalcification before you get a diagnosis. So if you have to do a frozen section on bone, what we do is make a smear, and that is just an estimate. Every frozen section, you will also see the pathologist saying, look at definitive histopathology. So there is a conceptual difference in the understanding. For bone, it requires decalcification, that requires an X amount of time, and that is why the issues take biopsy. The biopsy takes a certain amount of finite time.
Yeah, because if it's bone that you're biopsying, it has to be decalcified, and that always takes some time. So you'll get your report after.
And sir, is it safe to send the sample at two different places for biopsy? Because many of our consultants are doing that.
Why are you doing that?
Because
you don't believe the first.
Yeah.
You don't believe the first. No. You want a lottery, 2 out of 3. So you send it to 3 people, and then we'll go by this thing. So see, what you have to understand is tumors are heterogeneous. There is a different element of aggressiveness in various components of the tumor. So you will send the pathology to 3 different pathologists. All 3 can give you a different report. All 3 can be correct because you have sampled different areas of the tissue. So send your entire sample, whether biopsy or final specimen, to one pathologist. You don't believe him or her, circulate the slides in blocks. Don't ever divide the specimen.
I think it makes sense now to actually, if you have doubts, and even sometimes the pathologist may have doubts, you can always send your slides across to Tata Cancer Hospital or someone.
I mean, we still do that very rarely, but we send for international opinion when our pathologists, there are sometimes cases that, are really foxing. The clinical radiology picture doesn't fit in, the pathology looks completely different. So we send the slides in blocks. And slides in blocks are a very good sort of way to get varying different opinions.
We still send it still sends cases to your pathologist.
I know, we know that.
So, and one more thing, sir, one last question I want to ask that because in case of a patient is having malignant tumor, the chances of the infection which occurs in that one during the post-operative period or during intraoperative is the microbe pattern is different. Probably it is more anaerobes and gram negatives, what the literature say. So the antibiotic what we are using for tumor case, when we are operating on him, the pre-operative prophylactic antibiotic, that should be different, sir, or is it same for the tumor case also?
So there is a difference in prophylaxis and treatment.
Yeah.
When you are using antibiotics for prophylaxis, it's the standard. We use cefuroxime and we use single shot. We don't even, there is a concept that, it's immunocompromised. You will give prophylactic antibiotic for 7 days and 10 days. We don't do that. It's a single shot like any routine if it's a clean surgery. And if you're using it to treat infection, then you have to go based on your culture and sensitivity. So I think before we sort of wind up, we have Laskar with us. And today, and there are a lot of questions pertaining to new forms of radiotherapy, IMRT and proton beam and all that stuff. And there seems to be a misconception that these are magic, that you wave them like a wand and Laskar will cure every tumor under the sun. So fortunately for us, Laskar is very realistic. So I think we should use the last 4 or 5 minutes for having Laskar sort of just give a broad outline of radiotherapy, because radiotherapy is important to some extent in bone tumors, as Ashish said, especially Ewing's. And with the advent of these newfound modalities, we don't want some misconceptions among the young residents. So Laskar, maybe in 2 or 3 minutes, you can just encapsulate the various forms of RT.
Yeah. So there are two ways we deliver radiation. One is where you have the radiation source, which is actually away from the patient's body or the target that we call, and that's called teletherapy. It's like telephone, from a distance. So that's called teletherapy. And the other way we deliver radiation is to insert or place the radiation source within the tumor or very close to the tumor, and that is called brachytherapy. And brachy means close. So that is teletherapy and brachytherapy for you. These are the two ways we can do it. Now, within teletherapy, we started off with the older forms of delivering radiation, which was using the cobalt machine. And these cobalt machines were simple, and you could not really do very complicated treatments. But with the advent of newer technologies like, a linear accelerator, MLC, there you can conform the radiation to a target volume very tightly, and you can deliver very high doses. And that is why you have the technologies like IMRT, image guided radiation therapy, and all that. So these external beam radiation therapy techniques are used in conditions like Ewing sarcomas and osteosarcomas. The other one, brachytherapy, is used very effectively in conditions like the soft tissue sarcomas, where you can actually insert the radiation source within the target volume and treat. So these are the two broad ways. And like Dr. Puri mentioned, we have these new technologies coming in now, like proton beam therapies and carbon ion and heavy ion therapy. These have improved the way radiation is delivered and the cure rates. But this is not magic bullet. The basic principles of treatment still remains the same, and we have to use radiation therapy in the most appropriate manner to have the optimal outcomes. And like Ashish mentioned in his slides, it's been used for soft tissues and Ewing sarcoma in a large way. But yes, now even for tumors like unresectable osteosarcomas and chondrosarcomas, especially in the base skull, chondrosarcomas, they are very, very effective. Even in chordomas, you have extremely good control rates. So yes, they are effective. They're getting better and better. You can deliver radiation in a better way, but the principles, the basic principles of combining radiation with the other modalities remains the same, that you have to go by those basic principles. Yeah, I think it's too much of a lecture now.
No, so thanks. So basically what Laskar has said is just like surgery has got refined, radiotherapy is refined. You are delivering it better targeted with less morbidity. But that does not mean a radio-resistant tumor is going to become a radio-sensitive tumor. So the basic principles don't change. And that's what I wanted Laskar to sort of stress. And he's done that very well, because students will get a short note on this. And basically, they also have to understand that the concepts have not changed. Just like surgeons have improved, radiotherapists have improved. better target delivery, less complications, but the basic principles are unchanged.
So Ashish, you showed one case where you did this, what do you call the extracorporeal therapy, yeah?
Yeah.
So is that possible if the joint is involved? Or
We can do that, but usually what happens that there is a great damage to the cartilage, and
yeah, that's what
this leads to osteoarthritis. So we have done in few patients in upper limb, but yes, it leads to osteoarthritis, and there are some centers which do primary revision also for them, so that these issues are not. But we usually do it for intracalary resection, that is the diaphyseal tumors. Dr. Laskar, general orthopedic surgeons also encounter a lot of metastatic bone disease and hematolymphoid disease like myeloma as well. So can you highlight the role of radiotherapy in metastatic bone disease, whether the extremity or the spinal cord compression, and how do you take the call? How much of radiotherapy? Because it is very essential for orthopedic surgeon to refer to a radiation oncologist and should understand what is the value of radiotherapy in metastatic bone disease and myeloma.
So very quickly, in metastasis, radiation is used in 3 indications. One, you have a bone with a maintained bone integrity. That means you don't have an impending fracture, but you have um, refractory pain. So for pain relief, one, you can use at the sites of metastasis. Number two, if you have an impending fracture of a bone, especially if it is a weight-bearing bone and you want to prevent fracture, so you can do that. Number three, if you have a fracture and you have fixed the fracture, you still need to treat that site. So you give post-operative radiation therapy to that site. And more importantly, in patients with metastatic disease to the spine. So when you have spinal cord compression, radiation therapy can be a very effective modality to stabilize, to relieve the patient of the spinal cord compression, provided it is because of the soft tissue mass that is pressing. So pain relief, preventing spinal cord compression or a fracture or a fractured bone which has been fixed to prevent further progression of disease. These are the few main indications of palliative radiation therapy for various indications. Some of them respond well, some of them don't respond well, but they are extremely effective in palliating symptoms. In myeloma, it is extremely useful. Plasmacytoma is one end of the spectrum of this hematolymphoid disorder, where radiation therapy is the mainstay of treatment. You treat it with definitive radiation and no chemo. But whereas patients with multiple myeloma, again, radiation is used in conditions where there is an impending fracture, or you have a fracture already, or you have severe pain for pain relief. When patients with multiple metastases scattered all over the body, you can do something called hemi-body radiation, where you treat one half of the body to a particular dose, and again followed by treatment of the other half, again for palliation, that results in a very good palliation in a very short time. So these are the broad indications of palliative radiation and radiation in myelomas and plasmacytomas.
Thank you.
Good. I hope they all listen to Dr. Laskar very intently, because Ashish has been the shock and awe component. But honestly, as a general orthopedic surgeon, you are likely to see metastatic diseases 10 times more common than you would a primary malignant tumor. So what Laskar has said, you're going to apply 10 times more commonly than what Ashish has told you.
except maybe myelomas. I think
Yes.
myelomas are fairly common.
Yeah.
Multiple myelomas. Yeah. I see that quite often. Okay, so great. Thank you very much.
Thank you, everyone. Brilliant.
Ajay,
Thank you so
Siddharth,
much.
it was really a pleasure having all of you. And it's absolutely, I think, a wonderful sort of session with great insights from the experts. And thanks, Ashish, for taking all the effort to give such an elaborate talk, because I know it's not easy to try and make all that much information sort of in a concise manner, present it all in a concise manner so that it's meaningful within the short time that you have. So thanks very much.
So thank
Thank
me,
you so
John,
much.
for Thank me, John, for making Ashish make this presentation. You were going for the
I know, I'm sure.
when I told you Ashish is the best person for that. Anyway, bye everyone. Thanks. Bye.
Thank
Okay,
you,
bye.
sir.
Chalo, I think it's time.
Thank you, sir.
See you soon.
Okay,
Take care.
thanks a lot, Siddharth. It was good to see you. Yeah.
Thanks, sir.
Okay, bye.
Thank you, sir.
Bye.